Most of us eat something several times a day, and then we usually forget about what we ate until the residual undigested remainder unceremoniously alerts us as to its impending exit from our bodies. Ingested liquids are simply swallowed, but solid materials are chewed first to help break them up into smaller pieces. These are mixed with saliva to lubricate them, and then swallowed. In the stomach, ingested materials are mixed with gastric juices containing hydrochloric acid and pepsin. Most of the ingested nutrients are unaffected by gastric juice, but some hydrolysis of protein occurs. When the ingesta is parceled out to the small intestines, however, it is assaulted by pancreatic juice and bile, along with a number of enzymes produced by the cells of the intestinal lining. Proteins, lipids, polysaccharides, and even DNA and RNA are broken down into their organic subunits, which are small enough to cross the intestinal wall into the waiting cardiovascular and lymphatic capillaries. Absorption occurs, and then we eat again.
Hi, I'm Mike Shively, and this is Introduction to Anatomy and Physiology. Last time, we were talking about the immune system, the lymphatic system, and you have any questions about that since you've thought about it for a day or two? Adam?
We talked about the specificity of different antibodies to a specific antigen. How does the body produce that many millions, 10 to the 20th different antibodies and, specificity for millions of different antigens?
Yes, that's a really good question. In other words, how can we have DNA enough to produce millions and millions of different kinds of antibodies? As it turns out, are you familiar with a toy called Tinker Toy? Yeah, let's try again. Erector set, Lincoln Log. How about Legos? Okay, Legos. You know how you can take a set of Legos, which have basic building blocks, and you can make just an unlimited number of different kinds of things out of Legos. It turns out that when they've studied antibody structure, there's quite a few different, obviously, protein subunits, but those can be assembled, obviously, in many, many different ways. And so we don't have specificity for as many individual proteins as we do for as many antigens as we do the antibodies that can be produced, simply because we manufacture a given number of subunits and then assemble those subunits in different ways to meet the specificities required by a particular antigen. So that's how that works. Starley?
I had a question on the spleen. Is it an emergency source of blood?
Oh, good question. Spleen has been said, well, it has smooth muscle tissue in its capsule, and certainly in cases of hypovolemic shock, whenever the blood volume gets very low, the spleen will undergo some contraction and thus squeeze on the blood content that it has. It's not like it's got a whole bunch of blood that's just waiting to be squeezed out into the rest of the cardiovascular system, but it will undergo some contraction, in cases of low blood volume, and that small amount of blood as it is might be the difference in maintaining homeostasis in a certain situation. So it's shouldn't probably think of it as a source of blood for hypovolemia, but it does happen. It's a physiological phenomenon. Let's talk about the digestive system today. The digestive system, is it a visceral body system or is it somatic, y'all?
Visceral.
Visceral, and we know it's a visceral because why? In other words, what are the characteristics? Remind me again of the characteristics of a visceral body system, Eva.
It's tubular in design.
Tubular in design.
Has more, one or more openings at the body surface.
Okay.
And a mucous membrane.
Mucous membrane lining. Tubular in design, one or more openings at the body surface. How many openings at the body surface does the digestive system have? Two. Okay. And most of the structures within it most of the tubular structures have mucous membrane lining. Now, let's make a list of the parts of the digestive system. And let's start at the top end of the alimentary canal, which is the tubular part that ingesta contacts. And let's go to the other end, okay? So I will help you get started. I'm going to say mouth and associated structures. Now, by associated structures, I mean, like teeth and tongue and lips and palate and gums and all that. I want to cover all that right away. Mouth, including the oral cavity and everything, projects into it. What would be number 2? If that was number 1 on our list, what would be number 2? Adam?
The gullet.
The gullet. Fauces in Latin, G-U-L-L-E-T in English, is basically, think of it as the back part of the oral cavity. It's actually technically between the oral cavity and the pharynx, but they're continuous in there. All right, next, the third component. Starley?
The pharynx?
The pharynx. Now, the pharynx is a tubular structure that's actually common to both the respiratory and the digestive systems. So both ingesta and inspired and expired air pass through the pharyngeal region. Okay, we've had mouth and associated structures, gullet, pharynx, Eva?
The esophagus.
Esophagus. The esophagus is a musculomembranous tube that joins the pharynx to what, Seth? What's below the esophagus?
The stomach.
Stomach. Stomach's kind of an interesting organ. It's more of a storage vat than anything else, and a lot of people are caught by surprise by that. We think of digestion as occurring in the stomach. To be honest with you, there's relatively little hydrolysis and breakdown of foodstuffs that actually occurs in the stomach. Primarily storage, a little bit of breakdown of some protein, and that's about the extent of it. All right, after stomach, then what we're going to move to. Bryce, what would be next?
Small intestine.
Small intestine. Anybody here know how long the small intestine, from your reading, how long is the small intestine in a typical individual? Do you know, Bryce?
Is it like 12 feet?
A little longer. Somebody else, Eva?
Wasn't it about 21 feet?
About 21 feet. Obviously, it's got to be folded back and forth quite a bit to all fit in that abdominal cavity, doesn't it? About 21 feet long. So why is it called small intestine if it's so long, Adam?
The diameter of the lumen is
The
actually
diameter of the
smaller.
lumen. It's called small intestine because the diameter is relatively small. And then that distinguishes it from what part of the intestine, Seth?
The large intestine.
The large intestine. Now, the large intestine is only 5 or 6 feet long, but it has a much larger luminal diameter, and that's the reason it gets the name large intestine. Let's take a look at a graphic that summarizes these parts of the alimentary canal as we've mentioned them. Mouth and associated structures, gullet or fauces, pharynx, esophagus, stomach, small intestine, and large intestine. Now, once you mention these 7 components, you've mentioned the main parts of the alimentary canal, but you certainly haven't mentioned all the digestive system. Can anybody think of other digestive organs that are not considered to be directly part of the alimentary canal? Eva?
The liver.
The liver, and another organ that's very, very closely associated with the liver, Seth?
The gallbladder.
Liver and gallbladder, those are 2 organs that belong to the digestive system. Adam?
The pancreas.
Pancreas, an extremely important digestive organ. The pancreas produces more hydrolytic enzymes, more different kinds of hydrolytic enzymes than any other organ. And it's a vital organ, extremely important to the breakdown of foodstuffs. See, what have we left out? I'm having a little trouble because my mouth is dry.
Your
Bryce?
salivary glands.
Salivary glands, you bet, salivary glands. So we got salivary glands, liver, and pancreas, and gallbladder. Those are some structures that belong to the digestive system. They are connected into the alimentary canal by a duct system, but they're not considered to be part of the alimentary canal itself simply because foodstuffs do not directly contact their walls. Let's take a look at a graphic that summarizes those parts of the digestive system. We call these other digestive organs, if you will, to distinguish them from those that make up the alimentary canal. Salivary glands, actually there are 3 major pairs. We'll talk about those individually in a bit. The pancreas, the liver, and gallbladder. All right, so this is the digestive system then. We've got the alimentary canal, we've got these other digestive organs. What does it do? And we can break this down into a couple of real simple concepts. What is the functional purpose of the digestive system? And don't say to digest, okay? What do you think, Bryce?
To take food in.
Nutrient intake. We've got to get nutrients into the body. And that includes a lot of different processes. We'll look at a graphic here in just a moment on that. And besides nutrient intake, Adam, what else?
Waste removal.
We got to get rid of waste. We got to get rid of waste. Now, you can think of waste in the body being divided into kind of three categories, could we not? We could think solids, liquids, and gases. Okay. and I suppose that the digestive system could be involved in all of those at some time or another, but most of the liquid waste that we think of, what system should we be thinking of when we think of liquid waste, Starley?
The urinary.
The urinary system. And the gaseous waste that I'm talking about are what, Adam?
The
respiratory system, you bet. You bet. All right, let's look at a graphic that summarizes these functions then. Nutrient intake and solid waste elimination. Now, nutrient intake includes all of these processes that we've separately listed here. Let's just go through those just one at a time. Prehension is simply getting nutrients into the body. That would include stuffing them in with your hands or with your utensils. We include the drinking process. Mastication is the chewing process, just a 25-cent word for chewing. And we have to do that with some foodstuffs. Obviously, many of the liquids we don't have to masticate. We can swallow those directly. Deglutition is simply a word that means swallowing. Emulsification is a mixing process that occurs primarily down in the stomach. Hydrolysis must occur for most foodstuffs because most of the materials that we take in are in a complex chemical form that cannot be directly absorbed across the intestinal wall. So we have to hydrolyze the proteins back down to amino acids. We have to hydrolyze starches back down to simple sugars. We have to hydrolyze some of the other materials as well in order to absorb them. And finally, after all of these processes occur, then absorption can occur. It's kind of interesting from a philosophical standpoint, until we get here, until we get to the actual absorption across the intestinal wall into the bloodstream, into the capillary lumens, that material is not inside of our body in the physiologic sense. For that reason, you can take in orally some materials that are actually toxic to the body. If those materials are not absorbed, then they won't bother you at all. Many of you may have had what's called an intestinal series or a barium series at the hospital where they've had you swallow some barium sulfate and then radiographically examine various parts of your alimentary canal. Well, barium is a toxic heavy metal, but in the barium sulfate form, it's not absorbed, and as a consequence, it doesn't affect you in that manner. And then finally, solid waste elimination is primarily a function of the very last part of the alimentary canal. Any questions about the overall parts of the digestive system or the overall functions of the digestive system? All right, I want to bring up a model. We've looked at this model before when we were talking about the lymphatic system. This particular model, let's go to the overhead camera, is a mid-sagittal section through a head. And obviously here are lips, these are teeth, this is the oral cavity. Of course, this structure right here is the tongue. And if you look right here carefully, run your own tongue up against the roof of your mouth and it'll feel kind of firm up there. If you're pretty athletic with your tongue, you may be able to get it back here behind the hard palate and get it start touching the soft palate. Some of you just ate, so don't do that very much because it's pretty sensitive back there and you might induce a gag reflex. We got the hard palate and the soft palate. We get back in this region right in here. This is the gullet region. And then finally we get back into this area. This is the pharynx. Pharynx down here, and actually the nasal part of the pharynx is up here above the soft palate. And then moving on down here, the alimentary canal continues on down into the esophagus. Now this passageway over here is the air conducting passageway. This is going to be larynx and then trachea on down here. So you can see the close association of the respiratory and the digestive systems right here in the pharyngeal region. Some of you may have had the experience in your lifetime of getting a bolus of food back here, just ready to swallow it. When somebody at your dinner table tells an incredibly funny story and unable to control your mirth, you start laughing and blast a bunch of air from in the respiratory system up against this food material. And you may blast that stuff clear up above your palate here and end up with it in your nasal cavity, dribbling out your nose, or you can blast it right on out the oral cavity and have it exit that particular direction. You've also probably had the experience of getting something back here in the pharyngeal region, just preparatory to swallowing it, and maybe you're halfway through the swallowing process and you suddenly discover, you know, I don't think I've chewed that quite enough. Have you ever been there? Potato chips are kind of bad about that. You know, you get them back there and you haven't really chewed one particular part of that potato chip, and you send it down the esophagus with that sharp edge grinding against the edge of the esophageal wall there, and kind of get your attention a bit. At any rate, just wanted to kind of show you the close relationship of the digestive system and the respiratory system in this pharyngeal region. The pharynx is a kind of a shared passageway. Belongs to the digestive system, but it is shared with the respiratory system because air has to pass through it as well. I want to go up here to the oral cavity and spend a little bit of time on teeth. So I'm going to bring up a different model. Here we have a couple plastic models of different teeth. I can pull these apart and look inside as well. I want you to notice, first of all, there's quite a bit of the tooth that you can't see. This is a buried portion called the root. Some teeth have multiple roots, as you can see. The portion that sticks up above the gum line is the crown of the tooth, and the slight indentation between the crown and the root is considered to be the neck. So we have crown, neck, and root on this tooth, crown, neck, and root on this. Inside, there's some soft tissue within this dental or pulp cavity. That soft tissue is called the dental pulp. And a normal tooth is quite strongly anchored in the dental alveolus of either maxilla or mandible by some connective tissue proper called periodontium, or some people call that the periodontal ligament. The materials that form the different parts of a tooth there's three main ones. Up here, forming the outer part of the crown, is the hardest material in the body. It's actually called enamel, much harder than bone tissue. It's a mineralized tissue, but much harder than bone tissue. Covering the outer part of the root is a modified form of bone tissue called cementum, and then the inner softer mineralized material in here is called dentin. So we have enamel, cementum, and dentin as the three major materials forming a tooth. I want to bring up a larger model now so that we can see several teeth. Matter of fact, this is quite large model. I think we can look down on well, let's look down on top of with the overhead camera for just a moment. And these are the right lower teeth. These front teeth, this one and this one are considered to be incisor teeth. This is a canine tooth. These two are premolars, and these three are molars. Now, if we've got 1, 2, 3, 4, 5, 6, 7, 8 teeth in this particular quadrant, how many total teeth would there be in the mouth, Adam?
32.
32 total teeth in the full set of permanent dentition. If we take a look at a given tooth here, looking down on it as this overhead camera does, the side of a tooth over here that faces the tongue or is adjacent to the tongue is considered to be the lingual surface, and you can see the derivation of that word lingual. The outer side, depending on which teeth we're talking about, can be considered to be the palatal surface if you're talking upper teeth. It can be called the vestibular surface, and that vestibular surface gets its name from its adjacency to the oral vestibule, which is that kind of the space between your teeth and your cheek or lip. It's kind of where you stick something when you got a mouthful and the phone rings. You know, you jam it out there in the oral vestibule so you can say something. So this is the vestibular surface. The vestibular surface of more anterior teeth can be called the labial surface because it's against what? A lip. And the vestibular surface of these more posterior teeth can be called buccal surface because it's against a cheek. In addition to the lingual surface and vestibular surface, this surface in here, where you're supposed to jam some dental floss at least, once a year, that's called the contact surface, or its official name is approximate surface. And then the surface here that does grinding on these more posterior teeth, or kind of a cutting action on these more anterior teeth, is called the mastication or occlusal surface. These projections on the premolars and molars are called cusps, and there's some different names for different ones. And those of you who are headed for dental school will get into quite a bit of individual anatomy on individual teeth. But those are the surfaces. If we pull out this particular part of the model, if I can get this one disassembled, I want to tilt this up so that the camera can see the roots projecting down into the dental alveoli. And you can understand how it would be a pretty significant task to extract one of these molar teeth because of the multiple roots and how deeply they're embedded in the bony sockets that support them. All of the lower teeth are innervated by branches of the trigeminal nerve. It's actually the mandibular branch of the trigeminal nerve that innervates them, and all of the upper teeth are innervated by the maxillary branch of the trigeminal nerve. Now, I put this back together real quickly. If we actually give individual names to the individual teeth, there are several ways to do that. The anatomic naming of teeth is a bit clumsy and awkward because it requires so many words to actually go through. This tooth right here is an incisor tooth. It happens to be a right lower incisor tooth, and it happens to be the first or central right lower incisor tooth. This is the second or lateral right lower incisor tooth. This tooth is the right lower canine tooth. Right lower first premolar, right lower second premolar, right lower first molar, right molar lower second molar, and right lower third molar. So you understand how clumsy those anatomic designations are because they require several different words to actually get through. Most dental offices use an abbreviated system that shorthands this considerably. For example, we could just number the teeth within each quadrant, 1, 2, 3, 4, 5, 6, 7, 8, and then in this case designate them lower right. LR1, LR2, LR3, LR4, 5, 6, 7, and 8. And that's a much quicker way for a dentist or a dental hygienist to make a note in a dental chart for that particular patient. Another method that some dental offices use is to actually number the 32 teeth in the mouth, starting with the third upper right molar as tooth number 1, and then simply coming on around in a sequential manner, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, and then dropping straight down to the lower left third molar for 17, 18, 19, 20, 1, 2, 3, 4, and then 25, 26, 27, 28, 29, 30, 31, 32. So the 32 teeth in a full set of permanent dentition can simply be numbered sequentially 1 to 32 in that manner. Most dental offices use either the 1 to 32 system or the 1 to 8 quadrant system. Matter of fact, I think I've pulled a few of them, and I think they're probably more using the 1 to 32 system. So a given tooth is like tooth 17, and of course that's a particular tooth in the oral cavity. Yeah, Bryce?
So what happens like when people have their wisdom teeth out? Do they change the numbering on
They
those?
don't. The wisdom teeth, let's see, those are going to be teeth, number 1, 16, 17, and 32. If you've had those 4 teeth extracted, which a lot of young people today probably do, have had them removed, you simply won't have those teeth in your mouth anymore. So you won't, if you've had those teeth removed, all 4 of them, then you won't have a tooth number 1 or 16, 17, or 32. Any questions about that particular aspect of dentition? Let's look at a couple of graphics, make sure we catch ourselves up on some of the major points that we're making here. The permanent dental formula, full set of adult teeth, is considered to be 32. And we shorthand this and write it in this manner. 2 times the quantity, I, 2 over 2. Now a numerator in these fractions designates upper teeth, and a denominator, like the 2 is the numerator, 2 over 2. Denominator represents lower teeth. So we have I, 2 over 2, C, 1 over 1, P, 2 over 2, M, 3 over 3. And we have to multiply that by 2 because this parenthetical part of the expression simply talks about the right or left half of the dentition. So we've described either the right or left side, and then we multiply it by 2 since we have bilateral symmetry, and that gives us 32 teeth. Now, children have fewer teeth, as you know. Basically, they don't have what we call true molars. Their molar teeth, your molar teeth or mine, have no deciduous predecessors. So they have the same number of incisors, same number of canine teeth, and the same number of premolar teeth, but they don't have any deciduous molars. And so they only have a total of 20, 2 over 2 for I, and 1 over 1 for the canines, and 2 over 2 for the premolars. Eva?
Why is it that it's different times in your life you get different teeth? Like I understand when you're really young, your mandible and maxilla probably don't have room for those molar teeth, but what about when you're like 16, 17, the wisdom teeth start coming in?
Well, let's
Why
talk
is it
about
they
that a
wait?
bit. I know this is going back quite a ways for a lot of you, but most of you, when you were first born, had how many erupted teeth in your mouth, in all likelihood? 0. Let's go to overhead camera for just a second. If you have no teeth in your mouth, we start out that way and sometimes end up that way, at the other end of our lives. That's considered to be an edentulous state. You have no erupted teeth as a newborn infant, in most cases. And the first, because let's think about what newborn infants typically eat. What? They're doing the milk thing, right? And milk doesn't require just a whole lot of biting and chewing. Every once in a while, you have a baby that is born with some erupted teeth, and those aren't usually breastfed very long for obvious reasons. I know that was basically the way my wife weaned our number 1 son. When he started getting some teeth out, she said, "Okay, that's enough, and we're going to do the bottle thing and start on some other kinds of food." An infant normally will erupt their first teeth at about 6 months. So we're going to write edentulous. Let's go back to the overhead camera. Edentulous at birth. And the first teeth erupt about 6 months. I'm just going to write 6, M-O period. And we have a full set of deciduous teeth by about 2 years. Deciduous are the baby teeth, or the milk teeth, they're sometimes called. Now, Eva was asking, why is it, that we don't? I think it's simply because there's not room enough in the oral cavity, and it takes a while before we're starting to, the first foods that babies are, first solid foods are usually pretty soft solid foods. We don't start them out on peanut brittle right after we take them off the milk, So I think that's one of the reasons. Now, this child is going to deal with these teeth, a full set of deciduous teeth, then from 2 years of age until about 6 and a half or so. You remember your first grade picture, the one that Grandma still has up on the refrigerator someplace, that shows you missing maybe some front teeth. The deciduous teeth are replaced in a kind of a sequential manner starting at about 6 years of age, and by the time we're about 13, by the time we reach our teenage years, we typically have all of our permanent teeth except for the last molars, the third molars. And those third molars often don't come in for several years, or when they do come in, for a lot of individuals, there's not room enough in their oral cavity for all of them. They'll create a crowded situation. So That's one of the reasons why the wisdom teeth or third molars are often extracted, because it's creating some problems for the teeth in front. And often they'll come in angled and so forth and so on. Probably the reason for this change, the fact that we have this crowding is a change in our diets over the millennia. We're eating fewer solid roughage type materials perhaps today than generations and generations back millennia ago that mankind did. At any rate, there is specific things to know on aging, but I don't want you to know anything more than the fact that we come into the world with no teeth, get the first set of baby teeth. The first baby teeth erupt at about 6 months, a full set by about 2 years. Then the permanent teeth begin erupting at about first grade, somewhere along in there. And then over the next several years until we're about teenagers, that sequentially happens with various teeth. And then finally, the wisdom teeth sometimes never even try to come in, but in most individuals they do. Now, I have all of my wisdom teeth in, and I'm using them. I've got them. And but then I had one of the biggest oral cavities that my dentist had ever seen. And matter of fact, when we did the mold thing, to take the impression, he had to go back and get the one that was designed for small horses back there in the back, to get all of my teeth in there in the mold. So, any questions about teeth, Seth?
Yeah. Are there any examples of other animals that have deciduous teeth, or are we the only ones?
Oh no, most mammals are what we call dithyodontic. They have 2 sets of teeth. Most mammals are like that. So this is quite, our situation is typical in the mammalian world. Now there's some other animals that have some funny kinds of situations that the dentition varies. Like sharks, have continually replaceable teeth. They lose some when they bite somebody's leg off. It's one of the hazards of chewing on people, I guess. You're losing your teeth. But they have an infinite number of backups that can develop to replace those that are lost. And there's some other kind of funny situations in the animal world, like in elephants, where the dentition in the molar area all kind of grinds together into a single unit. It's all kind of fused together into a single unit, and so forth. So there's some interesting things in the various animals that involving teeth. Yeah.
So do baby teeth have nerves in them and stuff? Because the other ones that grow in after, and you can pull out the baby ones, they usually don't hurt too much.
Yeah, but by the time the permanent teeth start coming in underneath the deciduous teeth and physically shoving them up out of the alveoli, the deciduous teeth typically have a very shallow root system, for one thing. And then the blood supply gets cut off typically by this other tooth, the permanent tooth that's growing in under it. So there's usually very little pain associated with the normal natural shedding of a deciduous tooth. Although the grandchildren, I've noticed, are very careful about not wanting Grandpa to touch it. They want to make sure they do it on their own. Starley?
Does the number system of 1 through 8, is that because of how it comes in and how they fall out is in that pattern? Like, meaning most kids get those first tooth first and lose them first.
When the permanent teeth come in, they don't always come in, central incisors usually first, but it's not always, it doesn't always go completely around like that. Although that's a general, that general thing is true. Yeah. No, that numbering system was simply developed because it's a convenient thing to do. Everybody can count to 8, and we can start here in the front and go around, on the mid-sagittal plane and work around, I think. All right, let's take a look at a graphic that summarizes how we number teeth. The anatomic names, we mentioned, are kind of long and awkward, but they are very descriptive, and you know exactly where you are. The 1 to 32 numeric system, or the 1 to 8 quadrant system, are used in a lot of different dental offices. Some dental offices use this, some use this. Any other questions about teeth? I know we spent a little bit of time there, but some of you may be aimed at the dental profession in one form or another, and I wanted to talk about them just a bit before we move on. Let me pull this model back up and go back to the overhead camera then one more time. I know we've looked at this model several times. So we talked about teeth a little bit. The tongue itself has several different skeletal muscles within it and what we call intrinsic muscles of the tongue, as well as a number of extrinsic muscles that attach the tongue to other structures. So the tongue is attached up here to the mandible. It also attaches down to the hyoid bone, as you can see right here, and some other structures, in fact. And the tongue is extremely mobile, and it has important responsibilities in the mastication and deglutition parts of prehension. The tongue manipulates ingesta between the teeth and helps make sure we get that part that needs chewing on a little bit more positioned over between, premolars and molars, so that we can take another whack at it as we masticate it. Then, in order to swallow something, we actually bring, let's go back to that overhead camera one more time. We actually bring that bolus of material back into this general region, right here in the laryngopharynx, it's called, right next to the larynx. And the base of the tongue comes back and pushes on that bolus of food to get it started down the esophagus. There's some skeletal muscle tissue within the wall of the esophagus that assists that process of peristalsis by squeezing behind the bolus or above the bolus, as the orientation would be, in order to move that bolus of food down toward the stomach. I want you to get away from the idea that it's a gravity feed process. In other words, we don't just pour the ingesta back here and then it just kind of runs down the esophagus. There's actually some peristalsis or some contraction of muscle tissue that's involved in moving that bolus of food down. Now, if you take a look at your tongue in a mirror in a bathroom and get up close and personal with it, you'll notice that there are some little tiny bumps on it. And those little bumps are called lingual papillae. And there's several different kinds of those. But they're involved in kind of giving it a grip, so to speak. You know how your tires have treads? Well, those particular bumps are there in order to help the tongue get a grip on ingesta, to manipulate the ingesta within the oral cavity. Now, the little bumps that you see are not taste buds. Taste buds are microscopic. So you're looking at papillae, but you're not looking at taste buds. The taste buds are on the papillae, but are much, much smaller, way too small to be seen with the naked eye. Starley?
Sorry, what's the infected part in like a canker sore? Or like a each too much
Most
sour?
of those are, well, some of them start out, have you ever bit your own tongue? You just weren't kind of paying attention when you were chewing something and you left it in between the molars or something, and then you felt bad about it because it hurt for like 3 days after that. Sometimes you can damage the mucosa, the first layer there, physically, and chew a piece of it off, then that exposes the underlying tissue to bacterial infection and so forth. Some of the things that you're talking about, though, may be viral infections as well. There's some viruses that can cause some of those kinds of things. And they're quite painful and kind of get your attention and keep your attention for the few days that you have them. There's several medications, one called Orabase, which actually doesn't stop the infectious process, but sure makes things feel a lot better when you've got that thing going on. Adam?
So is it the lingual papilla that makes it feel like 80 grit sandpaper when a cat licks your arm?
Yes. As a matter of fact, cats have extremely long and posteriorly, incidentally, directed lingual papillae to the place when they lick you. It does feel very rough, doesn't it? Cats in particular have quite rough tongues. Much rougher. Dogs don't have that same development of the lingual papillae. I want to bring up another model now and lay it up here for the overhead camera. We won't be able to get all of the model on the camera, but I just want to concentrate, if we go to the overhead, concentrate on this central section right in here. Now, I know this is sideways with you, but here we have the head, and here's the esophagus coming down right here. It's that musculomembranous tube that's going to transport the swallowed ingesta down to the stomach. The initial part of the esophagus up here is called the cervical part. Then we have a relatively long part of the esophagus within the thoracic cavity. So this is the thoracic part here. And although this model doesn't have it on here, there's the diaphragm goes across right here. So the inferior part of the esophagus, which actually joins the stomach, I'm going to pull the stomach wall off here and lay it aside, is the abdominal part. Let me repeat that again. Cervical part, thoracic part, and abdominal part. This section right here that joins the stomach is the abdominal part. It's actually quite short. And this is just a transport tube to get the ingesta from the pharyngeal region up in here down to the stomach. Let's look at a graphic now that summarizes what we just said there. The three regions of the esophagus on this graphic are cervical region, the thoracic region, and the abdominal region. Kind of intriguing, the tissue in the wall of the esophagus. I mentioned that there was some skeletal muscle tissue in the upper part. The skeletal muscle tissue slowly but surely changes into smooth muscle tissue in the central part, and then down at the bottom it's smooth muscle tissue as well. So the initial part of the swallowing process, being skeletal muscle tissue involved, is a voluntary process. And so you decide that you're going to swallow something, you initiate that on a voluntary basis. But there is a point of no return on swallowing something. When you get it started down so far, you can just say, sayonara, it's gone now. I can't get that one back up to chew it anymore. Because finally it turns into smooth muscle tissue in that wall, which moves it on down to the stomach. Speaking of stomachs, I've got a dried one here. Let's go to the overhead camera. This one is actually blown up and dried. This is not from a human cadaver, but from a dog cadaver. But it does kind of demonstrate the overall shape. Now this one, of course, is fairly large because we've blown it up tight with air. When there's nothing in the stomach, it shrinks down to a quite small organ. Here's where the esophagus comes down and joins it, and here's where the small intestine leaves it. This would be the duodenum of the small intestine. So I want you to notice that it's kind of a U or J-shaped organ. It has what we call a lesser curvature here, and it has a greater curvature out here on this aspect. It's divided actually into 4 different regions. The part that I kind of have a hold of between the esophagus and the left-hand abdominal wall is the fundus of the stomach. The part right around where the esophagus comes in is the cardiac part. This part down here is the body of the stomach. And this portion that funnels down to meet the small intestine is the pyloric part of the stomach. Let me go over those parts again. Cardiac part around the esophagus, fundus of the stomach, body of the stomach, pyloric part of the stomach. Okay? Lesser curvature, greater curvature. Starley, did you have a question?
With a gastric bypass, what are they doing to the shape?
They're actually removing or clamping down part of the stomach so that ingesta can't get into it. Quite often they will put they've got some plastic rings that they can actually put on now so that you simply can't get as much ingesta into your stomach. And of course we're talking about situations of obesity where people are trying to control their body weight. Let's take a look at a graphic that summarizes what we just said about the stomach. 2 curvatures, 4 regional parts, and it produces or secretes 3 main substances. Now this is not the total list, but these are the ones that I want you to be aware of. Hydrochloric acid, HCl, pepsinogen, and mucus. The hydrochloric acid is necessary to convert pepsinogen to pepsin. And pepsin is a protein hydrolyzing enzyme. It will break down protein. This is the only hydrolytic enzyme that the stomach produces. And so the only degradation of foodstuffs that occurs in the stomach is some breakdown of protein. Adam?
So the hydrochloric acid actually doesn't break anything down?
Well, it's necessary it works in conjunction with the pepsin. The pepsin is the enzyme that breaks it down, but pepsin doesn't work except in an acidic environment. In other words, that's an enzyme that has a maximum activity at low pH levels, so it requires the acid environment. Also, the pepsinogen, which is the inactive form of the enzyme, is what the actual cells of the stomach wall secrete. And then when it gets out into the lumen of the intestine, the hydrochloric acid converts that pepsinogen into pepsin, which is the active form. Now let's stop and think. We've got a pretty powerful acid in the form of hydrochloric acid. We've got a protein degrading enzyme here. Is the stomach wall at risk? Yes. Sure it is. And that's the reason for that mucus. The third thing that you saw on that graphic was the fact that mucus was produced. If you look right here, That mucus, or quote slime, if you will, coats the inside of the stomach wall in order to prevent the stomach from autodigesting. Now, it's kind of intriguing. If you're a type A personality, uptight and concerned about things all the time, that those sympathetic impulses tend to reduce the mucus production by those mucus-producing cells, and so that makes you more susceptible to what? To ulcers. Makes you more susceptible to ulcers, exactly. All right, moving on from the stomach, mainly a storage vat, temporary storage, a little bit of protein breakdown, very little absorption occurs through the stomach wall. Some water can be absorbed through the stomach wall, but most nutrients do not go through the stomach wall into the bloodstream. Let's go on to the small intestine. I want to bring up this model one more time, and we'll look at a lower section of it here. Go to the overhead camera. Here was the stomach, right here, and here it's feeding into the small intestine, and all this pink-looking stuff here is small intestine. Now, I'll just tell you right away, this is the large intestine. It's gray and has this kind of pleated appearance. So what we have here are about 21 feet of small intestine that are folded back and forth, and so they can all that length can fit into the abdominal cavity. And those 21 feet of small intestine are actually divided into 3 regional areas. If we look at this graphic right here, you can see that it's divided into a duodenal segment, but that's only about a foot long, a jejunum, about 8 feet long, and ileum, I-L-E-U-M, about 12 feet long. Now, the small intestine is the main absorptive organ. It has a huge surface area, and primarily that's due to villi and microvilli. Now, villi are little teeny tiny finger-like projections. Let me pull up another model, and we'll go to the overhead camera on this model. These are villi, and to give you a kind of an idea of scale here, you can barely see these with your naked eye. Barely see them in a section of intestine with your naked eye. So each one of these little finger-like projections, of course, has a lot of cells on the outside of it, but these tremendously increase the total surface area of the small intestine. If we take a look at an individual cell from this, I want to just draw an individual cell while we're still on the overhead camera. Most of the cells here are going to be simple columnar cells, but their free surface is going to have microvilli. Now these microvilli are so small that you can't even see them with a light microscope. So villi are the finger-like projections that you can see, and then the individual cells have microvilli on them. Those two things, villi and microvilli, are the two main surface area increasers of the small intestine. And I've seen some facts and figures on it, but it's when you break it all down, there's a phenomenally large total surface area because of these little projections. And so the small intestine is the main organ of absorption. And it's also the main organ of hydrolysis, the breakdown. Most foodstuffs, most biological macromolecules are broken down into their subunit components by various enzymes within the small intestinal lumen. Now, some of those enzymes are produced by the small intestinal cells themselves, but a lot of them are actually found in pancreatic juice. The pancreas itself, and we're going to talk about this in a different session, upcoming one, but the pancreas itself produces pancreatic juice, which enters the lumen of the small intestine through a duct system, and that pancreatic juice has enzymes in it that break down proteins, lipids, DNA, RNA, carbohydrates, and all those sorts of foodstuffs. Any questions about small intestine? Adam?
Is the folding of the small intestine random, or does it always fold in the same way?
It's actually, I don't know if any of you here are deer hunters or not, but there's actually quite a bit of mobility due to smooth muscle contraction, relaxation within the wall of the small intestine. So it's not rigidly held in place, although the general folds are in the same general areas, but there's movement. It's kind of like if you watch one, you'd think it's in a living individual. You know, the abdominal cavity, abdominal wall open. It kind of reminds you of a sidewinder snake moving around, but very, very slowly. So there's this slow but sure movement of the various folds, and the bends move a little bit, but they kind of come back to the same general area. Let's go to large intestine for a bit, and I want to bring this model up one more time and go to the overhead camera a last time on it, and we'll look at large intestine. Again, the large intestine is shown in gray here. And it's about 5 or 6 feet long. Here's the small intestine, the terminal part of the ileum opening into the large intestine at this point. Then the large intestine comes up, across, comes down the other side, and has a little kind of an S-shaped curve here. And finally, the terminal opening down here would be the anus. Now, the large intestine is actually divided into some segments. Let me just put this paperclip pointer right across here and say, okay, this is where the ileum comes in. The portion of the large intestine below that is called the cecum. Projecting off the cecum is this very small finger-like projection called the vermiform appendix. A lot of people just call that the appendix. And then up above where the ileum comes in, we've got the colon, and it's divided into a ascending colon, and then there's a right colic flexure, a transverse colon here, then there's a left colic flexure over here, descending colon coming down this side of the body, left side, and then we've got a sigmoid colon down here. And then this straight portion that's a few inches long below the sigmoid portion of the colon, this is called the rectum, R-E-C-T-U-M, rectum. And then the terminal passageway that's about 3/4 of an inch long here is the anal canal. The terminal opening of the anal canal is the anus. Let's summarize what I just said on a graphic. Let's go to this graphic and see these words now. Total length of the large intestine is 5 or 6 feet. It's divided into an initial cecum, and then the largest part of the large intestine is colon. Then there's a rectum a few inches long, anal canal about 3/4 of an inch long, a couple centimeters, and then the final terminal opening is the anus. So anal canal and anus are not exactly the same thing, and certainly colon and large intestine are not exactly the same thing. Now, the large intestine absorbs water, dehydrates ingesta in that manner to form feces, holds those feces until a convenient location is found for deposit, time and location. But most of the true nutrients of the body, the major nutrients, have already been absorbed by the time ingesta reaches the lumen of the large intestine. So most nutrients are absorbed through the wall of the small intestine. Most of the physical breakdown occurs, chemical breakdown occurs in the lumen of the small intestine, and most of the absorption occurs through the wall of the small intestine. Let me go to this one model one more time, and we didn't talk about the layers of the wall, and I don't want to get into any details here, but again, this is a section through a small intestine. We've got these finger-like projections called villi. This inner layer of the intestinal wall is called mucosa, and it actually starts where this smooth muscle layer is right here. It's called muscularis mucosae, and then we've got some lamina propria and some lining epithelium, but that's mucosa. Then this layer right in here, which is primarily connective tissue proper with nerves and blood vessels in it, is called the submucosa. This area out in here, where we've got smooth muscle tissue in different orientations, some you see in transverse section, some in longitudinal orientation, is called the tunica muscularis. Tunica muscularis. And then finally, the outer layer out here is going to be serosa, or in some cases it's called adventitia, depending on whether there's a serous membrane present there or not. So it's, again, mucosa, submucosa, tunica muscularis, and then this outer layer on the outside, serosa or adventitia. Those are the layers. And we see these villi right here that we talked about increasing the total surface area of the small intestine. Now, in the large intestine, there are no villi present. So that's one of the ways that histologically or microscopically you can easily tell the difference between the large intestine and small intestine. If villi are present, small intestine. If villi are not present, it's large intestine. The lining epithelium throughout the alimentary canal is kind of interesting. In the upper part, down to the stomach, it's stratified squamous epithelium, all the way down to the stomach. And from the stomach on, including the stomach wall itself, the lining epithelium is simple columnar epithelium. Now stop and think. Stratified squamous epithelium is what we're talking about, several layers thick of flattened cells. That would not be conducive to the absorption process at all, would it? Simple columnar epithelial cells are able to absorb. They have surface modifications in the form of microvilli and some other things that allow them to be absorptive. And of course, those cells have to take in the nutrients first, and then from those cells, those nutrients can be absorbed on into the blood that's flowing through capillaries. That makes sense? So that's how ingesta nutrients eventually get into the circulating bloodstream. Any questions about the whole alimentary canal? Seth?
Yeah, what are some signs and symptoms of appendicitis?
Funny you should ask that, because I had an emergency appendectomy just a few years ago, so I'm very, very familiar. Severe nausea is what I had. And matter of fact, I just had vomiting all day long. And then finally, I got a localized pain that did happen in my lower right quadrant of my abdominal region that kind of pointed up and just I didn't want anybody to touch it right there in that one spot. But that's the main thing. But it does vary. You can have appendicitis with different symptoms than what I had. They removed it laparoscopically, and I was out doing yard work the next day, in fact. So. It was an unpleasant few hours, though, as I